Hello everyone, I welcome you all here at PLAB Mania. I will be your tutor during your PLAB1 journey. So the main aim behind launching the course is the fact that recently PLAB1 has changed its questioning criteria. It is more of conceptual rather than crammed information. So here we would be focusing on building the concepts rather than making you read mainstream sources which you can already do without any tutor. Also, the main purpose of today's video is to give you all a free trial on how things will be done here at PLAB Mania. I will not be asking you to open any books or consult any online platforms which you can do without me. Here I will be teaching you the essential concepts which will help you learn so that you can solve all questions on your own without having to cram them or memorize them. So keep watching the video to get yourself familiarized with our teaching methodology. I know that everyone has the latest version of PLAB keys and PLABable, med revision and whatnot. But I would appreciate that when you are here, please try to listen and understand the lecture, note it down and enhance your wisdom, because these lectures are going to be a combination of number of sources. Alright, so we can start off with CVS, right? So CVS has a number of different topics like angina, MI, then further we have NSTEMI, STEMI, and pericarditis, pleural effusion, infectious disorders, myocarditis, rheumatic heart disease, infective endocarditis, we have congenital heart disorders and whatnot. So do we need to do all of them? Well, if you want to learn for yourself, yes, of course, but talking about whether these topics are asked in the PLAB1 exam, well, most of them are, but not all of them. So just study smartly. If you're just studying for the exam and you want to score good in exam, so I wouldn't recommend going through the entire CVS. You can just open up Davidson and find like thousands of topics on CVS. If you want to do that for your own self, you can, but not for the exam. No, don't do that, especially if you have a very limited time for preparation. Okay, so in CVS, what should we start off with? Okay, so we are starting off with cardiac tamponade, right? So what is cardiac tamponade? This is your heart, right? This is the pericardial sac, and this is your cavity. This is your cavity, right? This cavity gets filled up with fluid. Can be serous fluid, can be blood, So this makes what? This makes pericardial effusion. Now, what's the difference between pericardial effusion and and cardiac tamponade? It's the same thing. So the main difference in pericardial effusion and cardiac tamponade is the duration of time that takes for the pathology to develop. So this pericardial effusion is slow developing, whereas cardiac tamponade is rapidly developing, right? Also, this pericardial effusion usually is not that disastrous, so the patient is very unlikely to present in the emergency. However, cardiac tamponade is an emergency, obviously. If we talk further about the symptoms, in pericardial effusion, only the ventricles are usually affected, so that causes decreased cardiac output. So ventricles are affected, the heart cannot get out of the blood cannot get out of the heart, so there is decreased cardiac output and decreased blood pressure, hypertension. But in cardiac tamponade, the fluid accumulation, it can be fluid, it can be serous fluid, it can be blood, whatever, it gets accumulated in the pericardial cavity in such a short duration of time that it almost fills the entire cavity, and it also affects the atria. So that gives the signs of right heart failure as well. We get increased JVP, right, along with decreased cardiac output leading to hypotension, and obviously there will be muffled heart sounds. Why? Because everything there is a lot of fluid inside the pericardial cavity, so we cannot listen to the heart sounds very in a very good way. So this is known as Beck's triad, and it is almost most characteristic for cardiac tamponade. What other features we will find? Well, if we go through a chest x-ray, obviously you will find a globular heart or enlarged heart, because if it occupies most of the chest cavity. So yeah, it's also known as globular heart, can be known as water bottle sign, leather bottle sign, because the heart is just so big. Here you can see an image of globular heart, which is typical for cardiac tamponade, also for pericardial effusion, because in both cases we're having fluid inside of the pericardial cavity, but again the symptoms are different. Please try to understand the concept behind the symptoms and how they are developing. It will help you understand the question in a better way. Alright, so coming back, along with globular heart or water bottle sign or leather bottle sign, we will also have pulsus paradoxus. Now, what is pulsus paradoxus? It's also called as paradoxical pulse or paradoxic pulse. When we normally inspire, there is a drop in systolic blood pressure during inspiration, but it's usually less than 10 millimeter of mercury. But when there is an exaggerated drop, let's say it's of 15, it's of 20, more than 10 millimeter of mercury, it is called pulsus paradoxus. Now, why does this normally happen? When we inspire, the chest cavity enlarges and the venous return increases, so that causes a normal drop in the systolic blood pressure. But when there is a mechanical pressure on the heart, it cannot work to its fullest. It can be due to some heart pathology, it can be due to some respiratory pathology. We will be learning more about it in the future lectures, so do not worry about it at the moment. Just remember that it does present with pulsus paradoxus, which is an exaggerated drop in the systolic blood pressure during inspiration. And along with this, it also presents with tachycardia, of course, and tachypnea, right? So what we talked about cardiac tamponade, how to differentiate it from pleural effusion. Basically, it's the same thing. It's the duration of the development of the pathology that differentiates the two conditions, so not a big thing. We had a look at the x-ray, we talked about pulsus paradoxus, we talked about Beck's triad. Now, coming towards the investigations. So, investigations include echocardiography, which is diagnostic, and also one thing, we can also perform an ECG. Now, what will ECG show? ECG will show electrical alterance. What is electrical alterance? Electrical alterance is decreased QRS complex, decrease in the amplitude of QRS, decrease QRS complex amplitude. Why? Because QRS shows the ventricular contraction, and since there's a lot of fluid, the heart is not working to its fullest, it will always present with a failed ventricular contraction and thereby decreased QRS amplitude. Coming towards the management, since it's an emergency case and you need to do something immediately, you will first of all, you have to ensure the ABCs. Obviously, that is the first protocol that you follow with every patient coming in the emergency: airway, breathing, circulation. Okay, good. Now you have to see if the patient is in shock or not. What is shock? Shock is decreased blood pressure, right? So if, let's say, we have a patient who comes to the ER with the typical signs and symptoms of cardiac tamponade, and the blood pressure is what, 90 over 60, that isn't shock. But if the same patient with the same symptoms comes with 80 over 50 blood pressure, the first thing that you will be doing is ABC, C, circulation. You will be giving IV fluids. right? And then you will go towards the specific treatment for cardiac tamponade, and that is pericardiocentesis, right? So what is pericardiocentesis? Basically, what is pericardiocentesis? It's the emergency procedure for cardiac tamponade, and it's almost always done. So what do? We have a patient coming to us with the with cardiac tamponade. We take a needle or a catheter and insert it in the fifth intercostal space, little left to the sternum. It's basically, the needle is basically advanced for 5 to 10 millimeters till it reaches the pericardial sac, and then we drain out the blood, the fluid, whatever. There is also another procedure which is called as subxiphoid window, but it's almost never asked in PLAB exam, so do not bother to think more about it. It's just a very long incision which is given up till the abdomen, and then we create a window for the drainage of the fluid and the blood. But it's almost never done for cardiac tamponade. It's usually done for long-standing cases in pleural effusion, and also it's an elective procedure. It's not an emergency procedure. So what do? ABCs: the patient is in shock, give fluid 2 to 3 liters, perform pericardiocentesis. Now deal with the cause. What caused caused the effusion or the cardiac tamponade? So if we talk about the causes, almost always in the exam you will be given a trauma patient, right? So trauma, it can be blunt trauma, it can be some penetrating injury at the left side of the heart, can be a road traffic accident with the blunt trauma, it can be a fall with blunt trauma. But for penetrating injury, there might be a stab wound at the left side of the chest, cardiac region, something like that will be given. And some other causes include the aortic root rupture, post MI. Certain drugs can cause this condition, such as anti-TB, isoniazid, and cyclosporins. So yeah, so we have also discussed what kind of question you will be given. You will be given a patient of trauma coming to you with Beck's triad, muffled heart sound, raised JVP, hypotension, can be in shock. What is the diagnosis? They might have given a chest x-ray, globular heart, enlarged heart. And what is the diagnosis? It's cardiac tamponade. The patient is presenting an emergency. Oh yeah, it's cardiac tamponade. The patient won't be going to a GP for an emergency. Please bear that in your mind. So this is how they might trick you in the question. And again, the treatment. Yeah, the patient is in shock. I will give fluids, 2 to 3 liters, normal saline. All right. The emergency management. The emergency management will be pericardiocentesis, specific for this condition. And again, the subxiphoid window is almost never asked. Do not bother to think about it. Okay, so there is also one differential that will confuse you a bit in the exam. A patient of trauma coming to you with raised JVP, right? They have given trauma and raised JVP. Trauma where? Trauma to chest. What will be the differentials? Typically for PLAB exam, you will have cardiac tamponade and you will have pneumothorax, and essentially talking about tension pneumothorax, right? So how will you differentiate these two conditions? Already discussed in detail that cardiac tamponade will present with Beck's triad, will have hypertension, you will have muffled heart sounds, you will have increased JVP. I'm just talking about the trauma and increased JVP. And again, talking about pneumothorax, that in pneumothorax you have to look for respiratory signs and symptoms. So what will be the respiratory signs? You will have to look for the breathing sound. Obviously, the affected side will have decreased breathing sound. You will have to look for mediastinal shift. Yes, very important, but it is usually manifested in very severe cases. The tracheal deviation, it will be given in most of the cases, but talking clinically, in actual practice, it's a very severe kind of condition which is very less likely encountered. Okay, so we'll have decreased breathing sounds, we'll have mediastinal shift, and we will have percussion note, which will be hyper resonant, right? We will not have enlarged globular heart, and we will not have muffled heart sounds. Why? Because the heart is fine, the cardiac region is fine, it's just something with the uh, with the chest cavity, right? So this is a differential that is very frequently asked in your PLABable exam, and please just try to understand the question, what they're trying to ask. Are they asking about the cardiac pathology? Yeah, they will be giving some sort of cardiac signs. Are they asking about the respiratory pathology? They will be talking about the percussion note, they will be talking about the uh, the breathing sounds, the stuff like, stuff like that. So please read the question, understand it, and only then answer it. This brings us to the end of today's free trial session. If you were able to gain something out of today's session, please feel free to contact us on WhatsApp. We will be announcing our crash course for PLAB1 candidates in a day or two. The prices will be very nominal, and we also will be providing group packages for you and your friends. The crash course will include 12 live sessions in which all major units for your PLAB1 exam will be covered, along with sample questions. We do have a WhatsApp group as well. Here is a QR code to it. Please join the group, as we do share PLAB material very frequently in the group. Also, do not forget to subscribe to the channel, as I will be making similar short videos on different topics to help you enhance your knowledge and understanding about frequently asked topics in the exam.